A 58-year-old man has hypertension. His doctor starts an ACE inhibitor. 2 weeks later, his creatinine goes up. The doctor looks at the result and doesn't change a thing. She expected it. Do you know why? By the end of this video, you will, and you'll be able to answer any RAAS question the USMLE throws at you. Drug side effects, clinical vignettes, lab findings, all from one mechanism. Let's build it from scratch. The Renin angiotensin aldosterone system has one job. When blood pressure drops, bring it back up. Every hormone it releases, every drug that blocks it, all trace back to that single goal. Here's the cascade we're building today. 5 steps. We'll fill them one by one. Step 1 is the trigger. RAAS doesn't run all the time. It turns on when the kidneys sense a problem. Specifically, 3 things can set it off: a drop in perfusion pressure, low sodium delivery to the macula densa in the tubule, or direct sympathetic stimulation through beta-1 receptors. When any of these happen, specialized cells in the wall of the afferent arteriole, called juxtaglomerular cells, respond by releasing an enzyme into the blood. That enzyme is renin. Here's your first pharmacology connection. Beta-1 receptors directly stimulate renin release. That means beta blockers suppress renin. That's one of the reasons beta blockers lower blood pressure. They shut off RAAS at the very first step. And here's a one-liner most people skip. Estrogen increases production of the substrate renin axon, Angiotensinogen, which is made in the liver. That's one mechanism behind oral contraceptive-induced hypertension. One sentence, tested. Step 2 is the substrate. Renin is an enzyme, so it needs something to act on. That substrate is Angiotensinogen, a protein made by the liver that circulates in the blood constantly, just waiting. Renin cleaves it, and the product is angiotensin 1. Angiotensin 1 is biologically inactive. It does nothing. Its only job is to become something else. That conversion is step 3. It happens primarily in the lungs. Angiotensin-converting enzyme, ACE, sits on pulmonary endothelium and converts angiotensin 1 into angiotensin 2. That's the active molecule. That's what the USMLE is actually testing every time it mentions RAAS. 2 major drug classes live here. ACE inhibitors, like lisinopril, directly block ACE. But ACE does 2 jobs. It converts angiotensin 1 to angiotensin 2, and it breaks down bradykinin, a vasodilator. Block ACE, bradykinin accumulates, and you get a dry cough. Hypertensive patient with a new dry cough on step 1? ACE inhibitor, every time. ARBs, like losartan, don't touch ACE at all. They block the angiotensin 2 receptor directly, the AT1 receptor. Same downstream effects, but bradykinin is unaffected. No cough. That distinction is tested constantly. And one more for completeness. Aliskiren is a direct renin inhibitor. It blocks step 1 of the entire cascade. Low yield, but if you see it, you now know exactly where it fits. Now we reach step 4, the engine of the system, angiotensin 2. Angiotensin 2 has 4 major effects, all aimed at one thing: raising blood pressure. Effect 1 is vasoconstriction. Angiotensin 2 constricts arterioles systemically, directly increasing blood pressure. But the critical detail is in the kidney. It preferentially constricts the efferent arteriole of the glomerulus. When renal perfusion is low, this maintains glomerular filtration pressure. It's protective. This is the trap, and this answers the opening question. When you block angiotensin 2 with an ACE inhibitor or an ARB, the efferent arteriole dilates. In a patient with normal perfusion, the drop in GFR is small and clinically insignificant. That's the expected creatinine bump, and it's acceptable. But in a patient whose GFR depends entirely on efferent constriction to maintain pressure, that dilation is disastrous. Think bilateral renal artery stenosis. Think severe heart failure. Think severe volume depletion. In those settings,
ACE inhibitor plus efferent dilation equals acute kidney injury. ACE inhibitor plus bilateral renal artery stenosis equals AKI. That is everywhere on the exam. Effect 2 is aldosterone release. Angiotensin II signals the adrenal cortex, specifically the zona glomerulosa, to release aldosterone. Aldosterone causes sodium and water retention in the collecting duct, with potassium excretion as the trade-off. Block angiotensin II and you reduce aldosterone. Less potassium is excreted. Hyperkalemia follows. That's the second major side effect of ACE inhibitors and ARBs, and it comes directly from this step. Here's a bonus exam concept. In bilateral renal artery stenosis, RAS is chronically activated. Renin is high, aldosterone is high, patients develop hypokalemia and metabolic alkalosis, just like Conn syndrome. The difference is renin. Conn syndrome starts in the adrenal gland, so renin is low. Bilateral RAS starts in the kidney, so renin is high. That single lab value separates them. Effect 3 is ADH release. Angiotensin II stimulates the posterior pituitary to release antidiuretic hormone, ADH. ADH acts on V2 receptors in the collecting duct, inserting aquaporin II channels into the membrane. Water is reabsorbed, blood volume rises, pressure rises. Effect 4 is thirst. Angiotensin II acts on the hypothalamus to increase thirst. That's behavioral water intake layered on top of renal retention. So, angiotensin II hits 4 targets at once: blood vessels, adrenal gland, pituitary, and hypothalamus. All 4 push blood pressure up. Now we zoom in on one of those, aldosterone, because it deserves its own step. Step 5 is aldosterone itself. Aldosterone acts on principal cells in the collecting duct. It upregulates ENaC channels on the luminal side, allowing sodium to enter the cell. It upregulates the sodium-potassium ATPase on the basolateral side, pumping sodium into the bloodstream. Water follows sodium, blood pressure rises. Potassium is excreted. Too much aldosterone gives you Conn syndrome, primary hyperaldosteronism. The classic triad is hypertension, hypokalemia, and metabolic alkalosis. Here's the mechanism of that alkalosis, and this is what step 1 cares about. As sodium leaves the tubular lumen, the lumen becomes electronegative. To balance charge, alpha intercalated cells secrete hydrogen ions into the lumen. That hydrogen loss from the blood is the primary driver of metabolic alkalosis. Hypokalemia contributes secondarily, but aldosterone-driven hydrogen secretion is the tested mechanism. Block the aldosterone receptor with spironolactone, a mineralocorticoid antagonist. It's used in heart failure, Conn syndrome, and resistant hypertension. The major side effect is hyperkalemia for the same reason ACE inhibitors cause it. The cascade is now complete. Now, let's see how step 1 actually tests this. Here's a vignette. A 65-year-old woman with type 2 diabetes and hypertension has an elevated urine albumin to creatinine ratio. Serum creatinine is 1.1. Which antihypertensive is most appropriate? Pause right now and write down your answer. This setup flags diabetic nephropathy. In diabetic nephropathy, the glomerulus is hyperfiltering. Intraglomerular pressure is pathologically high, and that pressure drives proteinuria and progressive kidney damage. ACE inhibitors and ARBs are the answer, not mainly to lower blood pressure, but because they dilate the efferent arteriole. That reduces glomerular pressure, reduces hyperfiltration, and reduces proteinuria. The creatinine bump that follows is expected. It reflects reduced hyperfiltration, not acute kidney injury from bilateral renal artery stenosis. That distinction matters. Now the follow-up trap. Same patient, 2 weeks later. Creatinine is 1.4. Do you stop the drug? No. A rise up to about 30% is expected and acceptable in a diabetic patient on an ACE inhibitor. You continue. Students who memorize that ACE inhibitors raise creatinine panic and stop the drug. Students who understand the mechanism continue it. That difference shows up in your score. 3 things you now own. First, RAAS activates when blood pressure drops. Juxtaglomerular cells release renin. Renin converts Angiotensinogen to Angiotensin 1. ACE in the lungs converts it to Angiotensin 2. Estrogen increases Angiotensinogen, explaining oral contraceptive hypertension. Aliskiren blocks renin. ACE inhibitors block ACE. ARBs block the AT1 receptor and don't cause cough. Second, Angiotensin 2 raises blood pressure through 4 mechanisms: vasoconstriction, aldosterone release, ADH release through V2 receptors, and thirst. Block it and you expect hyperkalemia and a creatinine bump. Third, ACE inhibitor plus bilateral renal artery stenosis equals acute kidney injury.